Good afternoon. I'll be presenting in my topic, which is a cross-sectional study to evaluate the effect of myopia on peripapillary retinal nerve fiber layer thickness, which is measured by optical coherence tomography. And the main aim of my study is to study the pattern of peripapillary retinal nerve fiber layer thickness in myopia. And we know that potentially blinding ocular disease associated with myopia is glaucoma, which is characterized by progressive degeneration of the retinal ganglion cells. And the morphological appearance of optic nerve head in myopia renders the clinical diagnosis and monitoring of glaucoma progression in myopic eyes challenging. And the RNFL thinning associated with myopia may mimic the RNFL thinning associated with the glaucoma, sometimes leading to overdiagnosis of glaucoma. And the objectives of my study are to evaluate the effect of myopia severity on average RNFL thickness and also on RNFL thickness in all four quadrants, and to evaluate the average RNFL thickness and correlate it with the axial length of the eye, and to compare any relationship between the central subfield foveal thickness and the myopia varying severity. And this was a cross-sectional observational study which was conducted at Dr. Tony Fernandez Eye Hospital with a sample size of 240 eyes, and time frame was from January 2021 to May 2022. And the myopic patients and also the myopic astigmatism patient in the age group of 16 to 50 years with best corrected visual acuity 6/9 or better was included. And those with a history of glaucoma or IOP more than 21 mm of mercury and cup dust ratio more than equal to 0.7, and those with prior intraocular surgery or laser treatment, those with retinal diseases, significant media opacity, and a history of diabetes, hypertension, and OCT signal strength which is less than 6 were excluded from the study. And all the patients had undergone a detailed history. Then visual acuity was assessed with the help of Snellen's visual acuity chart, which was later converted to a logMAR chart. And the near vision was assessed, and then a refraction was conducted with the help of a autorefractometer, and also a subjective refraction was carried out, and it was converted to spherical equivalent. And IOP was measured with the help of Goldman applanation tonometry, and slit lamp examination was done to assess any corneal or lenticular opacities, and fundus examination done to assess the cup dust ratio and also retinal macular pathologies, and axial length was taken with the help of optical biometer, and RNFL thickness and CSFT was taken with the help of Cirrus HT OCT. And RNFL was taken in all the average and also all the four quadrants, and CSFT was taken as central 1 mm in the macular cube scan. And based on the refractive error, the patients were grouped as low myopes, which those with refractive error less than -3 diopters sphere, and moderate between -3 and -6, and high myopes, which is more than -6 diopters, and each group had equal number of samples, which is 80 in each group. Coming to results of my study, there were 60% of samples were females, and nearly equal amount of right and left eyes, and with age group, maximum falls in the 25 to 40 years age group. And from this data, it is seen that the average RNFL thickness and correlating with the severity of myopia, in average, superior, inferior, and nasal quadrants, it has got a negative correlation, which is statistically significant because the p-value is less than 0.05. But in RNFL thickness in temporal quadrants, even though it shows a negative correlation, it is not that statistically significant when compared to the others. These are the graphical representation which shows a negative trend in the average, superior, inferior, nasal quadrants, but in temporal it shows a negative correlation, but not that statistically significant when compared to others. Coming to axial length, the average, superior, inferior, nasal quadrants show a negative correlation with a p-value of p-value of 0.01, which indicates it's a statistically significant data. But in RNFL thickness in temporal quadrants, even though a negative correlation, it is not statistically significant. And the graphical representation shows a negative trend in the average RNFL thickness, the RNFL thickness in the superior, inferior quadrants, and nasal quadrant, but temporal does not show a negative correlation. On comparing the severity of myopia with central subfield foveal thickness, it showed a negative correlation, but is not statistically significant. That is, there is no correlation between the severity of myopia and CSFT was seen. Coming to discussion. Our study showed that the RNFL thickness decreased as the myopia increased in all quadrants except the temporal, which was similar to that finding seen by the study by Ajay R. Kamath and Saeed Ahmed et al. But in study by Sali et al. Showed that the myopia increased, the thickness decreased in all quadrants except the temporal and nasal quadrants. But in study by Ho et al. And Boyd et al., they showed no significant correlation between myopia and RNFL thickness. And coming to axial length, our study showed that as the axial length increased, RNFL thickness decreased in all except the temporal, which showed a negative correlation but was not statistically significant, which was similar to that seen with Soniga et al. Study and Fahmy et al. Study. But in a study by Rocher et al. Showed axial length increased all the quadrants except the nasal and temporal, but Cerny and Leung et al. They showed a negative correlation in all the quadrants. Comparing the CSFT, we showed does not show a statistically significant relation between the myopia and CSFT, but in varicocele study they showed that as the myopia decreased, the foveal thickness increased, but in rugacetal they showed that as the myopia decreased, the foveal thickness decreased there. And the limitations of study did not include any emmetropes in the study, and the wide range of age group is included in our study. In the conclusion, as the severity of myopia increases, the axial length increases, inverse relation is there except in the temporal quadrant. There is no relation between CSFT and myopia, and there is no peculiar pattern of RNFL thinning myopia compared to glaucoma, and OCT is helpful in diagnosing preperimetric glaucomatous changes. It should be interpreted with caution in myopes, especially high myopes. And the recommendations are normative database, which is corrective for axial length and refractive error, should be incorporated while interpreting OCT, and it is better to depend not only on the OCT but also on the clinical findings. Thank you.
So, okay, good study. Why you have done the study? You are part of DMB training. Why you have selected this myopia?
There is a close correlation between myopia and glaucoma. So that in some patients it is difficult to understand whether the disc may be larger. So it is difficult to understand whether it is the glaucoma or it is a myopia. So not to overdiagnose or to underdiagnose a glaucoma, myopia, the RNFL pattern in myopia is needed to be known to the doctors.
Okay, finally after the study, what is your summary, what is your conclusion, what is the message you want to convey to the
that is,
audience?
while doing the OCT, it is necessary that we should look on the refractive error and also the axial length of the eyes so that we do not overdiagnose the glaucoma, or else it may be like, but the pattern is different. In glaucoma, the pattern of thinning is different to that of the, there is no peculiar pattern seen with myopes, but in glaucoma there is a peculiar pattern. In most cases it is followed that pattern, the superior thinning will be there. That is seen in most of the patients.
Can you recommend OCT as a routine for a diagnosis or follow-up of glaucoma? Can you recommend after this study? Cannot. Okay.
Do you know what is red eye disease?
Red eye disease.